Other things that you can do for the treatment of arthritis, physical therapy. There's almost no knee problem that can't be made better by strengthening the knee muscles. Okay, so one of the other things that we do, there are vitamins like glucosamine and chondroitin sulfate. We were fairly enthused about that 20 years ago. A lot of people still use them. You see them advertised all the time. They probably work in some people some of the time. From a scientific standpoint, the official position of the American Academy of Orthopedic Surgery is that there's no evidence that they work. That doesn't mean they don't help some people some of the times, and there's certainly no harm in taking them, but there's no evidence that they're clinically effective. Okay, so again, anti-inflammatory medication. Aleve, which is naproxen, Advil, which is Motrin, and then there are a slew of prescription anti-inflammatory medication. We used to prescribe these probably a lot more aggressively than we do now. There is some evidence that in certain patients, people with hypertension, people with kidney disease, it's not a great idea to be taking these long term. I mean, having said that, personally, if I'm going to play around the golf, I take Advil before I go. There's generally no problem with short-term use, but we're not quite as aggressive as we were in the past. Certain people, anybody that's on a blood thinner, for instance, has to be very careful about this. Bracing. Bracing is a short-term treatment, sometimes a long-term treatment for arthritis that provides stability. It'll keep you from falling. One of the problems with braces is the heavier you are, the less likely the braces are to fit. As you get heavier, your thigh gets bigger faster than your calf, so gravity will take the brace down and doesn't help you out. But it's one of the many things in our armamentarium of treatments. And then there's injections. So there's basically two types of injections that we put in the knee. One is cortisone, or a variation of cortisone. Generally works pretty effectively. We usually mix it up with a little bit of Novocaine or lidocaine. Sometimes it'll work for a month. Sometimes it'll work for 3 or 4 months. Sometimes we give people a shot and they're good for a year. That's generally the first line of treatment because it's cheap, doesn't require insurance approval, and it starts working right away. Not uncommonly, somebody who has arthritis, doesn't really need any kind of treatment, but they're going to Europe for 2 weeks and they're going to be doing a lot of walking. They might come into the office a couple days beforehand to get a shot because they know they're going to be doing a lot of walking. The problem with the cortisone is if you do it repetitively, there's some evidence it may actually accelerate the arthritis. So we don't like to do it if we can get away with it multiple times. The other problem is if you're a brittle diabetic, sometimes your blood sugar can go up, and so we have to be aware of that. So viscoelastic supplements or lubricants, things like Orthovisc, Synvisc, Euflexa. This is an old slide because the information on here is actually not correct. It says it works by replacing the joint fluid with a series of injections. It actually doesn't. What we found out over the last 20 years is it's basically a long-acting anti-inflammatory. But it's a series usually of 3 shots, although there are some that can be given as 1 shot. And it can last for 6 months or a year. The most frequently you can get it is 6 months. It's good for people who aren't quite ready for surgery or don't want to have surgery for whatever reason, or can't have surgery because they've got medical conditions or their age or such, and it provides them with oftentimes significant relief. Again, doesn't work all the time. My gestalt is probably 60 to 70% of the time people get significant relief. If you talk to your friends, you'll probably find some people that will tell you it's the greatest thing since sliced bread, and you will find other people that will tell you that it was completely worthless. It's one of the things we do. Okay, surgical treatment. There's a number of procedures, arthroscopic debridement, where you smooth out the cartilage. Meniscectomy, a meniscus tear in the presence of arthritis, we generally don't do, but if somebody has localized discomfort, that might be helpful. And then these are some other arthroscopic type procedures in the bottom. Arthroplasty is a total joint replacement. And this is a chondroplasty. Again, it's like mowing the grass. You smooth down the cartilage. Probably used to do that a lot more 10, 15 years ago. It's probably not really that effective in terms of long-term benefit. You might get 6 months or a year relief from it. Again, meniscus meniscectomy. somebody that has some arthritis, but basically their pain is localized in one area, the rest of their knee doesn't look too bad, and they've got a big meniscus tear, still somebody that might benefit from meniscectomy. Most of the time, if the arthritis is diffuse, a meniscectomy is not really going to do them as much good. And this is something called a microfracture, where you basically clean out the cartilage down to the bone and then drill some holes in there. There's also a thing called an Oates procedure, which is like a hair plug procedure. You take cartilage from somewhere else and fill in the defect. These are good for localized areas of arthritis, but they're really not that good for generalized arthritis, as the slide says here. Okay, so here's a couple things you're going to hear about. They read about them in advertisements, marketing: stem cell therapy and PRP, which is plasma-rich protein. So stem cell therapy is taking some cells from either an embryo or the cord, and you can determine which one you want to use if there's objections to one or the other, and implanting them into an area. These cells haven't differentiated yet, and the theory is that they will differentiate into the cells near them and therefore grow new cartilage. PRP is where you take some blood from the patient, spin it down, and get a plasma-rich protein, inject that into the area. Again, it will stimulate growth of cartilage. This hasn't really been tested. The official position of the American Academy of Orthopedic Surgery is that this is not proven to be either safe or effective. I am sure that at some point we will find out exactly what the role for these modalities are. There are people that are very, very proactive in terms of doing these things. We have this available in our practice. There are a couple guys that can do it. It's generally done as a last resort. It's never covered by insurance, and it tends to be very expensive. But these are the things that some of the athletes fly to Germany to get done, that type of thing. The holy grail of orthopedics is to get something that will cause the cartilage to grow back, and this is our attempt to do that. And as of now, we're not quite there. So the definitive treatment for significant arthritis in somebody who has a sufficient amount of pain to warrant surgery is a knee arthroplasty, what we call a total knee replacement. It's actually a resurfacing, but the term replacement came from the hip replacement. And this is what a knee replacement looks like. This is not the best slide in the world, but you've got a metal liner and a plastic spacer in between. This is another picture of a total knee replacement. Again, what you see here is we go in and we remove the cartilage that's damaged and some bone. Put this metal, this is either cobalt, chrome, or titanium, on the top of the tibia, bottom of the femur, and then put a little plastic liner in between there. Cover the kneecap as well. This is usually held in place about 90% of the time with bone cement. Sometimes it's press fit. This is a picture of an intraoperative picture of a knee replacement. You can see the metal's nice and shiny there. This is the patella, the kneecap. It's resurfaced. So we're not actually replacing the joint, we're just resurfacing it. So there's different types of knee replacements. And one is a total, where you basically resurface the entire joint, versus what's called a uni, which is where just one part of the knee is arthritic and you just resurface that. Some other things that are different, sometimes the surgeons will take the posterior cruciate out and then put something in its place to provide stability. Some surgeons leave the posterior cruciate in. It's about 50-50 across the country, and there's pros and cons of both. There's different ways of making the cuts, slight variations in the incisions that you use, and there are different companies that make the implants. But for the most part, with the exception of the first thing at the top there, knee replacements are very similar. So unicompartmental is when you just have a limited amount of arthritis just in one area, you just resurface that area. It's a little bit controversial. This is an operation that has been going on since the 70s. It would become very popular. People would look at the results. It kind of became unpopular, back and forth again. There's been a resurgence in the last 5 or 6 years again. It's slightly less involved as a surgical procedure. The disadvantage is that if you end up needing the entire knee subsequently replaced, the results aren't quite as good as doing a primary knee replacement. So it's a discussion you want to have with your surgeon if this is something that is an option for you. The recovery is very similar. This is, again, an x-ray of a unicompartmental, and there are some people, and I've done this rarely, but where the pain is just between the kneecap and the femur, and you do a patellofemoral resurfacing operation. This is a picture of a total knee replacement. Again, what you have here is, in this case, if you look at this plastic, you got this little bump up here. That is a posterior cruciate sacrificing implant. That's what I happen to use. And this plastic implant fitting in the box provides some stability, as opposed to here, where you don't have the box and you leave the cruciate in. During the course of my 30 years, I've gone back and forth. There is no right answer. In theory, the cruciate ligament, if you replace it, you've got guaranteed stability, whereas the natural cruciate may not be in good shape to begin with. Some people feel that the other is a little bit more natural feeling. There is no evidence that one is better than the other. Hence, it's 50-50 in New York. If you get your total knee done, they'll do one. If you go to Massachusetts, they'll do something different. Philadelphia is kind of in between. So some of these things are surgeon preference and not really based on any scientific evidence. So this is what an x-ray of a total knee looks like. Again, you've got the femur. You've got the tibia here. This is it from the side. You can see it's a resurfacing. It's not actually replacing the joint. In this particular x-ray, the surgeon did not actually resurface the patella or the kneecap. Most surgeons do. I almost always do. I would say I've not done it maybe 3 or 4 times out of a couple thousand joint replacements. There's pros and cons. At least some of the time people feel you can keep the patella. Most people feel you're better off resurfacing that as well. So the technique. All knee replacements involve this sequence of events. You make an incision in the front of the knee. You remove the bone and cartilage using some type of a guide. You take measurements. You generally cement or sometimes press fit the components in. You put in the plastic spacer, polyethylene, and you close the wound. Anybody that does a knee replacement for the last 50 years, that's what they've been doing. This is the standard way of doing it. It's been around forever. We have these jigs. Total knee is very dependent on the geometry of the cuts being exact. So this is a carpentry operation. So we've got these jigs to make sure that the alignment of the knee is lined up perfectly. It's perpendicular to the force that's being transmitted from your hip to your ankle, or the rate of wear of polyethylene or plastic is going to be increased, not to mention the fact that if you're off by enough, the knee will look like it's crooked. So this is a standard way of doing it. Now, this is something that came out about 10, 12 years ago. What they did is they said, why don't we send x-rays or CAT scans of these knees to the factory, and we don't make up a custom knee, but we basically make a mold up based on the measurements so that you just kind of slap this on top of the knee and drill through it, make your cuts through it. It makes it a little faster. I did use it for a while. I think they're probably not quite as accurate, but there's still some people that use it. It's another way where technology can kind of try to make things simpler. And there are times, like for instance, if you had a big deformity up here and you can't put a rod up the femur, that this is useful to have. This is what I generally use. This has been out maybe 5 years. This is essentially computer navigated measurements. This little thing about the size of your iPhone. You put it on the knee, you drill it into the femur and the tibia. You mark a couple landmarks, move the leg around a little bit. It makes registration points, and it makes the cuts look absolutely perfect every time, which is important. It probably adds, in my hands, about 5 minutes to the operation. I think it's time really well spent. So it's kind of a computer-assisted navigation system. Again, there's no solid evidence that, in terms of studies, that this necessarily is better than doing the old-fashioned way. There's some evidence that you're not likely to be grossly off with this, but I think it's really a tremendous advancement in the last 5-10 years. So you hear about robotic surgery. So robotic surgery is not the surgeon is in the room having a cigar while this robot does the operation. Robotic surgery is basically a souped up version of what I just showed you the last slide. You've got a big machine that you then make marks on the knee utilizing the CAT scan that was done beforehand, and that guides you with making the cuts. They have one at Robert Wood Johnson. They have one at Princeton, 2 of the hospitals we go to. I have used it. I don't I think there are times when it's nice to have. I don't think it's necessary. Some surgeons are bigger proponents of it than others. Again, if it's a guide that you have, there is no evidence that any of these particular methods is necessarily better than any others. I happen to like the computer-navigated ortholine. Again, some of the surgeons use this, and some do, depending on what they're doing. There's a term you'll see, minimally invasive, for knee and hip arthroplasty. What does that mean? Nothing, actually. It doesn't mean anything. It's a marketing term. It can refer to the size of the incision. It can refer to whether you cut the quadricep or not, or the type of implant used, uni versus non-uni, or the type of operation done. So the size of the incision, if you compare what we're doing now to what we were doing 25 years ago, the incisions are much smaller. Having said that, you're limited by a couple of things. If you're heavy, it's going to take more of an incision to get to where you need to be. If you weigh 120 pounds, that's a smaller incision than if you weigh 250 pounds. More to the point, there is evidence that if you try to do an operation through too small of an incision, you will stretch the skin and you end up with a worse looking scar. And what people are generally interested in is a nice looking scar and a faster recovery. The amount of bone removed, again, is a function of the amount of arthritis. There are surgeons, there's one in particular who advertises that we don't cut the quadricep. In the history of total knee replacements, no one has ever cut the quadriceps. What they are referring to is there's something called a muscle sparing incision. These lines are off. The traditional place where you make the incision is right along here. You go up along the edge of the tendon, and then you have to dislocate the kneecap this way. There is a way where you basically take the incision up this way and then go like this. So, and then you move the whole muscle over so you don't have to cut here, okay? If they said we don't cut the tendon, we tear the muscle, it wouldn't sound as good, so they don't say that. But the fact is you have to move the patella to the side. There is very clear evidence that there's no benefit from one procedure or the other. There's actually some evidence that the complication rate is higher when you do this. It's certainly something that's only applicable on thin, non-muscular patients. So really what you want to deal with is, you get what your surgeon is comfortable doing. No evidence that one is better than the other. Again, it was something that's been used as a marketing technique for some people, but both are adequate. So I'm going to talk a little bit about the downside of surgery in general, the risks and complications of knee replacements. So anytime you have an operation, there are risks to anesthesia. That's why we send you to your cardiologist or your medical doctor. We can never lower the risk to zero, but we can optimize the risk. Make sure your potassium is good. Make sure your heart rate is regular. Make sure your diabetes is under good control. We won't do it if your hemoglobin A1C is above a certain point. It's usually 7.5. And we do most of these, probably 95% under an epidural anesthesia because it's safer and it's also quicker recovery. DVT, or deep venous thrombosis, and PE, pulmonary embolism, blood clots. If you don't treat this, there's a high incidence of this problem. So the standard of care is that we give everybody a blood thinner afterwards. The way you treat a prophylaxis against DVT, we get people up and move them right away. We give them special sequential compression stockings when they're laying in bed. And we give them a blood thinner. Most surgeons prefer to give aspirin because it's simple, it's cheap, and it doesn't have a high bleeding complication rate. In other circumstances, you might use one of the other blood thinners, Coumadin, or one of the newer ones, Xarelto. Surgeons generally are less happy with that because if you think about it, obviously you want to thin the blood so you don't have a blood clot. We don't want to thin the blood so it bleeds into the joint. So there's a balancing act there. The rate of DVT PEs with appropriate prophylaxis is very low. So infection, the rate of infection, any surgeon that does any surgical procedure at all, there's a certain infection rate. With total joints, it's well under 1%. Problem is, it's a big problem if you get one. Generally means you're going to have one or more additional operations. And we take great strides to prevent that from happening. We generally wear spacesuits during the operation. We limit the number of people that are in the operating room. We give antibiotics. So, it's one of the advantages of having this done in a facility like an outpatient surgical center where they don't do infected cases there ever. but anybody that has done enough total joints has had one, and it's a problem. It generally involves then taking the implant out and putting antibiotics in there for a month or so. So we go to great risks to lower that. That's one of the reasons why we won't do the operation if your blood sugar is out of control. It's also why if you're going to have a joint replacement, we will send you to the dentist beforehand to get what's called a dental clearance, which is we want to make sure there's no infections in your mouth because we don't want them spreading to your knee. And generally speaking, surgeons will tell you afterwards that if you go to the dentist for a dental clearance, cleaning, or dental work, or if you go to get a colonoscopy, we want you to take antibiotics an hour or two beforehand to keep you from getting an infection. So implant failure, fairly uncommon, that the implant would actually break, but sometimes they can loosen over time and need to be revised. We like to think now that about 90% of our implants, total knees, will last about 20 years. Stiffness is a problem some of the time. It's patient specific. Generally, the biggest predictor of stiffness after the operation is stiffness before the operation. But this is why it's important after your surgery that you go get your physical therapy for the first couple of weeks to get your knee moving. And then obviously there is a small percentage of people who still have some residual pain after the operation, even when everything is done perfectly. Most studies that have been done show that patient satisfaction rates are 90 to 95%. That means people feel that they're completely better or a lot better. There are some people, maybe 5%, that feel that they're not that much better, and you're going to get a couple percentage that feel that they really aren't better at all or worse. So over time, the use of regional anesthesia, which is spinal or epidural, nerve blocks, where the anesthesiologist will inject some Novocaine into the nerves up in the thigh where that kind of deadens the pain in the leg for a day or two. We inject long-acting local anesthesia into the joint itself, the same kind of stuff the dentist puts in your mouth, have dramatically reduced the need for narcotics, have dramatically limited the amount of pain that people have after this operation. That's why we can now get people out of the hospital or out of the surgery center much quicker. We use a lot of different medications now instead of one size fits all. It used to be 20 years ago, you had a total knee, you sat in the hospital with a morphine pump for 2 or 3 days. We don't do that anymore. Use of anti-inflammatory medicine like Motrin, IV or PO Tylenol, Tramadol, Neurontin or Lyrica, and then long-acting controlled release medications like Oxycontin, or we just use oxycodone now, has dramatically reduced the amount of pain. We're also interested in significantly lowering the amount of narcotics that people get. Obviously, the opioid epidemic is an issue. We try to keep people from getting constipated. We're trying to get them urinary retention. So we try to give people a minimum amount of narcotics. Now, everyone's different. I've had many patients who literally take one pill and that's it. Most of our patients, we give them a prescription. I give them a prescription for 30 oxycodone to leave the surgical center the same day. Maybe 20% of the people get one refill. That's it. We no longer have the large-scale use of the narcotics like we did 5 years ago. Bleeding. There's a drug called Transimic Acid. It's actually an old drug that we started using a few years ago. It's miraculous. It has essentially eliminated the need for blood transfusions. I can't remember the last time I've given a blood transfusion following a total knee. It's probably been 10 years. We don't even type and cross our patients for blood anymore. Used to be you had to donate your own blood or get somebody to donate it for you. There are a few types of patients that can't take this, people who have bad renal disease, people who have a recent stent or have had a history of a blood clot. But 95% of our patients, it's given intravenously about 15 minutes before the surgery and then 3 hours later. It has dramatically decreased bleeding and help with our wound management as well. We don't use drains anymore. So a combination of better surgical technique, smaller incisions, improvements in implant technology and anesthesia, along with aggressive post-operative patient protocols, have resulted in quicker recoveries, less pain, and improved long-term function. So the basic operation from a surgical standpoint, what we do really hasn't changed that much, but with the many advances, the experience has changed tremendously from the standpoint of the patient. The length of stay. When I was a resident, admittedly that was 30 years ago, the length of stay, average length of stay, what's called a DRG for Medicare, was about 21 days. Can you imagine staying in a hospital 21 days right now? The average, now actually Medicare considers this an outpatient procedure, which means you can stay overnight, 23 hours. Almost all of my patients, if they're done in the hospital, they will go home the next morning. And again, we do a lot of our younger, healthier patients in the surgical center and send them home 4 or 5 hours later. The recovery time in terms of going back to work dramatically decreased. Activity level, age, because the equipment and because the outcomes are so much better and the surgery is so much quicker and less risky, we can both do these surgeries on people that are younger than we used to. Used to be you had to be 65. Now I think, ideally you want to be at least 50, but and the older the better, but we have a more leeway. Likewise, we're willing to do it on people who are older because the stress to their system is a lot less than it might have been 10 years ago. And the longevity, again, much greater than before. Again, traditionally, this is an operation that's been done in a hospital. In our practice, that's Robert Wood, that's Capital Hopewell, that's Princeton, St. Mary's. But more recently, in our case, in the last 5 years, we've been doing a lot of them in our surgical center. It's more efficient. You've got essentially concierge service. You've got a physical therapist waiting for you, waiting for your spinal wear off to give you therapy, as opposed to going and waiting in line for the therapy. It's much cheaper, and of course the insurance companies love that, so does Medicare. And we believe there are a lot fewer complications. Now, in fairness, some of that's because we cherry pick the patients. If you have sickness, if you have a lot of medical problems, we won't take you there. But we don't, for instance, do anybody that has any kind of infection in the surgical center, so the risk of infection, we haven't had to my knowledge, I've never had a patient with a total knee that had an infection that was done in the surgical center. So this is an option, and it's becoming more and more common, both pushed by patient demand and also by payer demand. So who's a candidate for total knee replacement? As a general rule of thumb, if you're not sure whether you need a knee replacement, you probably don't need it. You don't need a knee replacement because you have aches and pains once in a while. You have knee replacement so that you can enjoy activities of daily living. It depends on your age and health, again, your weight, what you're planning on doing. If you're running a marathon every 3 months, you're not ready for a total knee yet. So we need to have realistic expectations. It's done so people can enjoy activities of daily living. So this is something that's appropriate to do. Bike riding, not a problem. So basketball, yes, a little basketball with your kids. This is not something you should be attempting with a total knee replacement. So golf, absolutely. This is one of the common sports that you can have a knee replacement and go back a month or two later and play. Skiing, yes or no. You probably shouldn't be doing the slide on the right. You probably shouldn't be doing double black diamond moguls. If you want to go down the green slopes and take it easy, there's people say that's okay. Again, canoeing, that type of thing, that's fine. Tennis. The textbook answer to this is they say doubles tennis yes, singles tennis no, which obviously doesn't make a lot of sense. But if you're the type of person that's going to be diving into the corner to get a shot and returning it, it's probably not an operation that you're ready for yet. If you're playing doubles tennis with a couple of your friends and you're going to hit the ball back and forth, or pickleball, which I've never personally played, but I'm told it's a smaller area, then yes, you can play that. You just can't go pivoting and twisting like crazy. Knee replacement's a phenomenal operation. The only time that I would tell somebody that they should have a knee replacement, instead of them telling me that they want one, is if your knee starts to get really crooked because of that asymmetric wear. And then I'm going to say, if you don't do this, it's going to be a lot harder to do. You're going to have a poor result down the road. But other than that, it's really based on the patient. It's based on what their medical situation is. It's based on what their activity level is, what they plan on doing, their expectations. But for the people that it is an appropriate operation, it's really a game changer. And again, this is a lecture, and I've said a lot of very generic things, and I'm going to answer some questions if there are any in a minute. It really comes down to a very individualized discussion between you and your surgeon in terms of what's a reasonable treatment. And again, almost all the time, we start out at the right end of the spectrum with the weight loss and the exercises and the injections and all that. Sometimes I'll get somebody sent to me that's already had that done, or their knee is just so severely deformed that there's no point in doing that. But generally speaking, we start out and slowly progress to somebody needing a knee replacement. Again, I guess I'm done to talk, and Jen, if you want to put some questions through now or whatever, I'm ready to do that.
Sure. Sorry, everyone, we lost internet connection there for a second, so I appreciate you staying on with us. And Dr. Nolan, can you see a Q&A button on your screen?
Q&A. Chat. Oh, Q&A down here. Yes, I can. Okay.
If you click on that, you should be able to see some
Yes, I did.
questions
Something popped up
there for you.
What about artificial cartilage? Great idea. We don't have that technology yet. Like I said during my talk, the technology, the holy grail of orthopedics is to get something to have a normal, or anything that's biologic can last, forever. Anything that's artificial starts wearing down from day one. So yes, a biologic resurfacing would be better, especially in a younger person. And there are techniques that are good for limited areas of arthritis, either the microfracture or there are procedures where we take cells and grow them in culture and then put them back in. They're incredibly expensive, and they're only good for young patients with very small localized areas. So the next one I have is, are you able to kneel on the floor, look under the furniture, and do garden work? The answer is yes, but we generally discourage a lot of kneeling because you're putting a lot of pressure on the plastic kneecap. So I generally encourage people not to do it more than they have to, or to put a little pillow there. But there are people who love gardening, or they kneel for religious reasons, whatever. You can physically do it. We like to think that our knees can get to about 120 degrees of flexion. That's considered normal. In order to kneel and sit on your heels, you got to get to about 135. Not everyone gets there for that, but yes, the short answer is you can. Do I recommend seeing a rheumatologist for arthritis? So a rheumatologist is somebody who treats arthritis medically. Where you start out doesn't matter. When we send patients to rheumatologists are when they have inflammatory arthritis, things like rheumatoid arthritis, lupus, that kind of thing. They require certain types of medications that, that's way over my pay grade. If somebody needs something more than an anti-inflammatory from a medical standpoint, they go to a rheumatologist. So if there's any question, we'll do a lot of screening, we'll order the blood tests, and if there's any question, I'll send people to rheumatologists. There's certainly nothing wrong with going to a rheumatologist and independently getting a second opinion, but it's mainly for rheumatologic type of problems. Does cannabis help? Well, I don't think anybody knows is the short answer. Maybe relieves the stress of having pain in the knee. Whether it actually hurts the pain, I don't think it's been out and studied long enough to say. Basic exercise for bad knees, absolutely. You can go online and we have handouts we give people, but I really think I'm a big proponent of physical therapy, and that doesn't mean you need to sign up for a lifetime membership at a physical therapy facility. I like to send people there once or twice, have them learn the exercises, have somebody watch to make sure they're doing it correctly. You don't need a lot of fancy equipment. You don't need even to go to a gym. But yes, doing exercises to strengthen the quad is helpful. What about when your knee is constantly on fire? Well, again, it depends on what the source of the pain is. That sometimes refers to like neurogenic pain. It may not be from the arthritis. So it really requires diagnosis. There are medications that can be used for that, where you find out there's an infection involved. Again, I don't know if this questioner was referring to pre or post-op surgery, pre-surgery or post-surgery, but burning oftentimes refers to irritation of the nerve. When doing the surgery, do you clean up other things and or bone spurs? Yeah, we resect all the extra bone spurs when we're doing the operation. What about someone diagnosed with osteoporosis? It's a completely different diagnosis. If you're extremely osteoporotic, we have to be concerned about the implant settling, so that should probably be evaluated first. But osteoarthritis and osteoporosis really aren't specifically related. If you have moderate OA, is it normal for your knee to hurt at night? It can. Again, as I said before, there's not always a great correlation between how bad your x-rays look and how much pain you have. So if you're having pain that's keeping you up at night, you definitely need a medical orthopedic type person to evaluate you, number one, to make sure there's nothing else more serious going on, and then again, start you on your treatment, whatever treatment is appropriate. Is knee pain somehow related to vitamin D deficiency? That's really more osteoporosis. I don't know that knee pain is specifically caused by vitamin D deficiency, but certainly you want to make sure that you're taking your vitamin D and your calcium for a whole bunch of other reasons. So please go over how many cortisone shots is appropriate each year, bone on bone. So some people will say 3 to 4. It depends on the patient. So if somebody's 92 years old and they have bad arthritis and the shots help them and they're not a candidate for surgery, I think most doctors are going to throw out the textbook and they'll give them a shot every 2 months or so because it's improving the quality of their life. You get somebody who's 50 years old, you probably don't want to do more than 2 or at most 3 a year, because if that's not working, you really need to move on to plan B. Once you get the meniscus work done, is knee replacement imminent? No, absolutely not. We do scopes in people in their 20s, and the hope is that they won't have a knee replacement either ever or not for a long, long time. I've been doing this for 32 years, and I see patients that I did arthroscopies on. The guy did an arthroscopy and an ACL in 32 years ago that I see intermittently, and he's still doing fine, doesn't have a knee replacement. It's possible if you have a full meniscectomy done, you could. I've been diagnosed with a meniscus tear in my left knee. I'm waiting till I get my COVID vaccine before I get surgery. What do you suggest I do to alleviate my pain discomfort? It really only hurts sitting in a recliner and laying in bed. Well, I would say take some Advil or leave, or possibly have your doctor give you a shot of cortisone to buy you a month or two. Do the exercise. If you haven't had a physical therapy eval, just have them show you the exercises. You'll get tested for COVID if you have surgery. So it's a pretty safe thing to do. Nobody in the center, including any of the patients, are there unless they've been tested for COVID. But if you want to wait for that, then I would say, ask your surgeon for a shot. If you do get a shot in the knee, then you will not be able to have a knee replacement for 3 months. Not a knee arthros, but even a knee replacement. And somebody is typing, a difference between cobalt, chrome, and titanium, which is better? Well, there's pros and cons. The titanium has a lower modulus of elasticity, which what that means in English is it's not as stiff. And so I think surgeons prefer to use that if they can. You also don't have to worry as much about metal allergy, nickel allergy, which is still pretty uncommon. There are certain instances, the femur oftentimes is made of cobalt chrome, and then we can cover it with a ceramic if necessary. If it's, the cortisone injection, I think I asked already. I saw 3 years ago, I saw me, shot of cortisone, recommended therapy, which I had for a couple months, and I have not had any pain since. Is that normal? So for the cortisone shot to last that long? The cortisone shot didn't last that long. What happened is, in this case, we gave you a shot of cortisone to cut down the inflammation. You start on the knee exercises, and you're back to your baseline. And so the cortisone lasts in your system a couple days, and the effect is a month or two. So, but yes, I see people all the time where I'll see them, I give them a shot of cortisone and some therapy. I see them 4 years later, 5 years later for a shoulder problem or something else. Let's see, when should I get an MRI? Well, in general, people get too many MRIs. Generally speaking, unless you have a locked knee or blood in your knee or something like that, you should get an MRI. Number one, if your x-ray shows that you don't have a lot of arthritis, because if you do, there's no point in getting an MRI. It's not going to change anything. If you failed at some reasonable course of conservative treatment, maybe a shot, maybe a couple visits with a physical therapy, almost all of the commercial insurances will insist that you get an x-ray, a couple visits with a physical therapy, some of them say 6 weeks, but you can get away with a couple visits, and some other conservative treatment, and fail that. Why? Well, let's just say you're 50 years old and you come in with an MRI that shows you have a small cartilage tear. You haven't had conservative treatment. You're going to want an operation for that, right? You're going to try the simple stuff first. If the simple stuff works, you don't need an MRI because you're fine. If the simple stuff doesn't work, then you get the MRI. So as a general rule of thumb, I would say people probably, they've heard of MRIs, they think it's the answer to everything. It's a phenomenal test. I order probably 15 to 20 a week. But, there's algorithms that exist, and they exist for the most part for a reason. There are certain things that you can have that will kind of put you to the front of the line. You know, if you have an injury and you've got an obvious ligament injury, if your knee is locked. Otherwise, you generally have to wait a couple weeks. How quick is recovery from meniscus surgery? How much therapy is needed? There's a range. Some of my patients don't even, they go to therapy once. I've had, you know, people, I did ACLs in there, out cutting the lawn 2 weeks later. It depends on you. It depends on your age, how athletic you are. It depends on what type of meniscus tear you had. Generally, people are off crutches by the end of the day or the next day. Certainly a week would be a very long period of time. In terms of going back to athletic activity, I think the range is anywhere from 2 to 6 weeks. I've had Synvis for 10 years. I exercise for my back and knees, and knee pain is not so bad. Should I keep getting the shots? See, this is something I didn't get into. You get the Synvis shots if you think they make you feel better. There is no evidence that the Synvis or the Orthovisc makes the arthritis itself any better. The advertisements that you see in the newspaper where they show an arthritic knee, and then they show a year later, they show a perfectly normal knee, and they're doing this under ultrasound, which is a racket for the most part. That's a sham. The Synvisc, the Orthovisc, it's designed to relieve your symptoms. If you feel it's helpful, and you're the one that's got to schlep in there and get the 3 shots or the 1 shot and put up with the discomfort from that if it's uncomfortable, then do it. If it's not helping you, don't do it. So what percentage success have you found with the injection of Duraling? That is weeks to feeling much better versus little benefit. I've had a couple patients which I use it, and first of all, it's very expensive. And the theoretical reason to use it is it's not as absorbed as much, so you don't have to worry about the blood sugar being bumped up. So when somebody who's a brittle diabetic, I will use it. Although admittedly, I've had a patient, at least one, that I gave it to and their blood sugar was still went up. I've had a couple patients that did really well. I've had some other people that didn't seem to help as much. I like to start with the simple, less expensive modalities first. I can't give an exact number, but I know that is like a lot of things that we do. We're not even aware of it, but some of this stuff is really expensive. And as you are aware, we're already bankrupting our country with some of the stuff we do. So, you know, if you need it, it's great, but it's not the first line of treatment. And I'm sure the guy that sells it would tell you something different, but that's my opinion. In knee replacements, can they be done safely as outpatients? And yes, we've been doing them for 5 years as outpatients. You had an orthopedic surgeon tell me they should not be done as outpatients. Well, maybe he's not comfortable doing that. I don't know. I mean, some surgeons take 3 hours to do a knee replacement. Most surgeons who do a fair number of them, and I mean, speaking for myself, I probably do between 100 and 200 a year. A high-performance, high-volume surgeon is considered, I think, more than 50 a year, are going to do most knee replacements inside of an hour. Most patients can be done as outpatients, depending on their medical circumstances. The simplest thing that I will tell you is if you're not comfortable with that concept, then don't do it. Now, having said that, the insurance companies and Medicare are going to kind of drive it that way anyway. In fact, they tend to push things too far in that direction. But I can tell you, I've been doing it for 5 years, and the key is patient selection. You don't do it with somebody that should be in a hospital. It's the same thing with doing the arthroscopy or an ACL reconstruction. When I was a resident, people were in the hospital for 3 days. Now, I haven't done an ACL reconstruction in the hospital, and I can't remember the last time. Let's see what else we got here. Do I recommend CBD for arthritis? I personally don't. I don't think there's any evidence one way or the other. That's not to say it doesn't work. Is the surgery okay for a person with G6 deficiency? The short answer is yes. You have to be careful of the medications you use, but I've done it. You can't use a sulfa drug, and there's a couple other things we can't use, and to be honest, I have to look it up. I always do, but this is not a problem. What about lidocaine shots in the knee? Well, lidocaine lasts about half an hour, and there is some evidence that lidocaine is what we call cytotoxic or chondrotoxic, so it can actually be bad for the cartilage. Generally, you put a little bit of lidocaine in with the cortisone because it gets rid of some of the inflammation, it gets rid of some of the acute pain that would exist for the cortisone for the first few minutes. So a little bit, yes, but in general, not really. Can you wear an elastic brace worn over the counter? Can it be hurting me? Not going to do any harm as long as it's not too tight. Bracing is a trial and error thing. You want to try a neoprene knee sleeve with a hole in the middle first, or an ACE one, absolutely. They're inexpensive. We've got braces that we dispense out of the office. They're a little bit more involved. They're probably more expensive. This insurance may or may not cover them. That's like the next level up. If you're talking about a brace for arthritis, it actually, it's called an unloader brace. There you're talking about several $100s. They're effective in some cases, but again, it gets into the weight of the patient. But yeah, there's nothing wrong with trying an over-the-counter brace first. How much do the RC with the stem cells procedure cost? It's like buying jewelry. It's how much do you have, really. We do it at almost our cost, and I think it's about $1,000. But I've seen it advertised for $5,000–6,000. I mean, since it's outside of the insurance thing, it's kind of buyer beware. So I would do your research on that. Call a bunch of offices, get an idea what the price is, because there's a variation price, because there is no set price. Dr. Willis was my doctor and leaving my practice. Yes, I'm one of Dr. Willis is going to be one of my ex-partners in another couple weeks, and I would be more than happy to see you if you have a meniscus tear. My practice is basically the surgery I do is probably about 70% knees, maybe 3/4 of that knee replacements, and then the rest knee arthroscopies and ACLs, and then I do hip replacements and rotator cuff repairs. That's most of the show. I mean, I'll still do a couple other simple things, but over the last 10 years, I've kind of narrowed. Most guys finish, when I finished, doing a little bit of everything. I used to do spine surgery and things like that, which I wouldn't dream of doing now. So I'm basically a knee and hip surgeon, and then I do some shoulder, rotate certain types of shoulder surgery as well. But yes, I'll be happy to see you if you're interested in coming. So I have no questions now. I'm not sure what that means.
Yes, you answered all the Q&A questions, Dr. Nolan. However, you do have some here in the chat.
Okay.
So I think you answered the G6 deficiency one. The knee is constantly on fire. The elastic brace hurting. Is it possible to hurt? One, I don't think you answered, and I apologize if you do and I missed it. Are all surgical staff tested for COVID, and have they all been vaccinated?
The answer is, are all surgical staff tested? I believe so. I'm pretty sure at the surgery center they all have been. I can't speak for the hospitals. Have they all gotten vaccinated? I think a lot of them are. I think there are legal issues with mandating it. I think we have mandated. I don't know that they've all been vaccinated yet. Speaking for myself, I have my vaccination scheduled for next Saturday. I've been tested, so I can tell you how it is in our practice, and I'm pretty sure this is everywhere. We wear masks in the office, real masks, not the cloth things. We do the social distancing. If you go into our waiting room now, it doesn't look like a train station like it might have looked 2 years ago. We got spaces in between the seats. We clean the rooms every patient. So a lot of, and then we have to get our temperature taken and all this stuff that everybody's doing. So it's unlikely you're going to get COVID from your provider. Put your mask up. That means keep it over your nose, which I'm not sure why people don't understand that, but some don't. That's probably not a high-risk place to get it. But so yes, the answer is within the net, most of our people have been tested, if not all, and we are in the process. I think, and maybe Jen, you can answer this or not. I think almost all of our people have gotten the vaccine, or a lot of them have, and all of our surgeons have. So that's that. You got any more questions? And I got one here. It's I'll just read. Dr. Einhorn has recommended a total knee replacement. Is there a wait time for scheduling? Well, obviously that depends on his schedule, number one, and I can't speak for that. I think Dr. Einhorn only does it in the surgery center, so if he's doing it in the hospital, you would have to refer you to one of the other doctors who operates in the hospital. Then there's that schedule to take into account. And then there's medical clearance issues. You need to get dental clearance and things like that. In general, there's no such thing as an emergency total joint. Somebody comes in my office in great medical shape and they want a total knee replacement. It's generally not the case that they're done inside of a month. You're usually looking in 1 to 3 months. Again, it depends on how backed up we are, things like that. But between the surgical center and we have privileges at 5 hospitals, we have a lot of capacity. So it's generally not a big waiting time. Let's see, anything else?
So I have another one in the chat. It says, I have severe arthritis in my one knee. I have done injections with Dr. Avalone with St. Mary's, but my health insurance changed where they don't take my insurance any longer. But I have not had my three injections in 3 years. How do I see a doctor there, and if they take my insurance?
Well, obviously, I don't know what kind of insurance you have. Our office is one floor up, the next floor up at St. Mary's, over Avalon's. And John's a great guy and a good surgeon. So you'd have to call our office and see if we accept your insurance. I obviously have no idea what it is. And then you would just call, my name's Dr. Nolan, and there's a couple other guys in the group that do knee replacements. Sign up for the shots. We'd examine you. Bring your x-ray if you've had it, unless it's been at St. Mary's, and we can pull that up on the computer. So we can document those things. And then it's just a matter of getting, again, depending on your insurance, if you have Medicare, we can start at the day you come. If you don't, generally has to be approved, and that might take a week or two to get you started on the 3 shots.
I think you have one last question here, Dr. Nolan. It just says, have knee pronation with pain while standing. I'm guessing they want to know if there's anything that they can do with regards to that.
So that depends on why that is the case, and that someone would need to look at you structurally to see whether it's actually a foot problem, whether it's a hip problem, which a lot of times it is. You might have stiffness in the hip, you might have a flat feet. And generally, the first thing I would think about would be to give somebody some knee conditioning exercises. Also, check an x-ray. Well, the first thing is to do an exam. And then if it's a knee problem, probably get an x-ray of the knee and possibly consider orthotics or some type of an exercise program. And then again, it depends on how symptomatic you are and what exactly the problem is. So I can't really give you a more specific answer than that.
Okay, I think that's it. We've answered all the questions. Dr. Nolan, thank you very, very much. That was such an informative presentation, a lot of good information. I'm sure everyone really appreciates you volunteering your time for this. Again, if anyone's interested in an appointment with Dr. Nolan, you can see the information on your screen. You can go to the www.mbortho.com and register for an appointment through there, or you can call 855-896-0444 and schedule through one of our registrars. Secondly, if you do have any additional questions with regards to this presentation, you can go ahead and email programs@mbortho.com. Those emails come directly to me, and if it's medical related, I can consult with Dr. Nolan and I will be sure to get back to you. In the meantime, we appreciate you coming and we look forward to seeing you next time. Thanks so much. Have a good evening.
Thank you.